Hello, everyone. My name is Gabriel Altit. I'm a neonatologist based at the Montreal Children's Hospital in Canada. And today I'll be speaking about neonatologist performed echo for the evaluation of systolic and diastolic heart failure in the context of neonatal shock. It's really a pleasure and honor to be able to present here at the GENS 2025 conference among such an amazing group of experts and colleagues, both in the audience and as well as presenters. I've been learning a lot. So these are my disclosures. And the objective of my presentation will be to speak a bit about the mechanistic aspects of cardiac function of the newborn, both for the right and left ventricle, understand some of the key conventional markers that we do use for systolic function, but recognizing also some of the challenges we face to define normal from abnormal cardiac relaxation when we speak about diastolic heart failure. And then we will discuss some of these NPE/TNE indices to guide diagnosis and targeted management in the context of neonatal shock. Before we dive into the topic, I do want to mention some of these important references that I've put here from a North American and European perspective. There's been really brilliant guidelines and other resources that have been developed through the years to provide some framework to the management of complex hemodynamic situations in the context of neonatal cardiovascular evaluations and management, and both at the level of the American Society of Echo as well as the European Society for Pediatric Research. So the talk that was given to me is about trying to better understand what's systolic from diastolic heart failure and in the context of shock. So we will actually divide and go back to physiology and try to understand these four concepts, both in the clinical space and then how we can apply this to phenotype of our patients in some of these mechanistic research projects and trials as well. So if we go back to physiology and definitions, we're all ready. Let's talk a bit more about cardiac function. We know that cardiac function, it's a bit like densing. It's the continuous process from filling of the ventricles to ejection eventually in the outflow tract and distribution into the cardiovascular system, whether it is in the pulmonary or systemic side. This is very dependent on the architecture of each ventricles, the crosstalk between these ventricles, as well as the precise activation of the conducting system and fibers, which are supposed to disperse normally throughout this myocardium to really promote harmonious contraction, eventually relaxation. And so, we simplify this by creating these two phases of what we call systole and diastole. But as you can understand, this is a continuous process, and obviously the two of them are quite interacting. And we usually spend about a third to half of our time in systole and then the rest in diastole, which obviously gets disturbed when we start reaching faster heart rate. And functionally, this ends up being with a mechanical contraction, mechanical relaxation that eventually leads to these ejection and filling phases. Now, when we look at trying to better understand what's heart failure, I think it's important to first identify what's systole and what's diastole. And conceptually, systole means the ability to contract and eventually eject blood, creating a stroke volume and cardiac output. And diastole is really that portion of the cardiac cycle where you get an early phase of passive and eventually an active relaxation. And of course, when you get failure of this relaxation or you start having adverse compliance of your muscle tissue, you end up with elevated filling pressures or inadequate filling. And eventually, this can lead also to reduced stroke volume and cardiac output. So at the bedside, I think that if you see this patient on the left, it's quite obvious that you have systolic left ventricular dysfunction where you barely see this left ventricular cavity move. And the management approach of this patient will be much more dictated by supporting, cardiac function and not necessarily flooding these patients with volume. Versus on the right-hand side, you see a patient who has very severe hypertrophy in the context of infant of diabetic mother, and where these patients can become quite tachycardic, filling becomes quite a problem, and because of that, you get very low cardiac output. And so these patients actually may need more therapies that will provide some rate relaxation and improvement of filling. And so these are obviously the extremes of the spectrum. And there's probably many patients with cardiovascular instability that fits in the middle of this perspective. The problem that we get is often how do we better define these patients and study them in a very much so methodic way. Tamponade is on its own a complete different mechanism, but it is ending up into what we call a diastolic dysfunction. So it's the extreme example of compressing through extra cardiac pressure. And you can even see this right atrium, which is usually a very, very low pressure chamber, actually, flapping because the wall is getting compressed by the intrapericardial pressure. In this case, it's really drainage that you need to do. So if we go back to physiology, we know that pressure is a function of flow times resistance. And if you look in the two circuit, the pulmonary or systemic side, it means that the RV output times PVR plus the downstream post-capillary wedge pressure or LA pressure, depending if you have some degree of pulmonary vein stenosis, they may not be exactly the same, but distal stream pressure will give you your pulmonary arterial pressure. And when you look at aortic blood pressure, it's the LV output times systemic vascular resistance plus the right atrial pressure, which is the distal draining pressure. The outputs are typically impacted by both stroke volume and heart rate, which we know can be very much so affected by many of the processes we see in neonatology, either myocardial immaturity, issues with heart-lung interactions, mechanical compression, heart rate impacting also, preload and filling time, ventricular size that is very limited, stiffness because of inflammation and hypertrophy, as well as afterload that can be poorly tolerated by immature hearts. And so if I bring you back to some of these very key concepts, afterload is typically me trying to bench press 300 pounds. I obviously will have a bit more difficulty. And we know that newborns are very intolerant to high afterload, with the right ventricle being more sensitive than the left ventricle. Preload, we all know the Frank-Starling curve, where at some point, you reach a plateau where giving more fluid will not provide more contractility or increased stroke volume. But having very low preload is like, you trying to walk in the desert with no water, you're not going to go very far. And finally, heart rate can also influence a lot what's happening at the level of the heart, both from a filling perspective, but also from activation of contractility. And at some point, you reach a part of the loop where you're really detrimental to the contractility of your heart. So that's more for the heart failure. So one of these mechanisms is broken, we end up with poor cardiac output and eventually, the flow that will diminish. But when we talk about shock, it's really the idea of matching oxygen delivery and nutrient delivery to the actual metabolic demands. And there's flow being part of that, of course, and cardiac output and the distal resistance and the microvasculature. But there's also a whole component of matching to avoid going into like a hyperperfusion state or an underperfusion state. And the idea is really to find this nice balance. And so I do want to remind ourselves collectively that, echo or some of the metrics we have at bedside will uncover some of the mechanistic targets. But you still have to be at the bedside to recognize that there is a concern of perfusion adequacy and to try to understand the matching, because sometimes more does not mean necessarily better. And so to understand how some of these ventricles may be affected, I think we need to go back a bit to the configuration. The left ventricle tends to be a bullet shape. It's more conical. It does have a smooth internal layer, and it tends to be a bit more bulky because it has a three muscle layer with a higher LV mass. The LV will contract with a tendency to contract towards the inside. Neil Patel does a beautiful dance that is available on YouTube, I believe, to try to, show the difference between the myocardial contractility on the LV side versus the RV side. But, the LV really contracts towards the inside. There's really a minimal element of longitudinal contraction. And then there's also an element of what we call rotation, where you get this ringing effect, which may be quite disturbed in the context of immaturity. And you can see that there are different layers that are sliding in different types of orientations, which provide really the maximal performance of this left heart, both for the actual contraction but also relaxation. And so more and more, we try to better understand how some of the diseases that we see in newborns may either affect immediately the heart and eventually long term, and or how the heart function eventually could translate later on to important outcomes or phenotypes. And so that's like a 3D representation of this, mechanics of the left heart, where you see a big component of contraction towards the inside and a minor component of contraction from the longitudinal perspective. DLV, although is a bullet shape, is quite complex. There's different segments, and these segments may not necessarily be affected the same way. We also know that based on this segmentation of the heart in the 3D space, you may have also different territories of coronaries that may be preferentially affected, and that's also true for the subendocardial region versus the epicardial regions of the heart. The right ventricle on its end tends to have a much more complex triangular configuration. It tends to have two muscle layer and so is less bulky or has lower mass, at least eventually once this RV remodels in the postnatal stage when PVR are dropping. So that's why it tends to less tolerate increase in the afterload. It is a ventricle that tends to jump up and down in terms of its function. So it's a contraction that is more longitudinal with a peristaltic motion towards the outflow tract. And then typically when the PVR have dropped and are infrasystemic, the interventricular septum also bulges into the RV cavity and the free wall tends to come towards the interventricular septum. Now, the RV is more complex in terms of its geometrical configuration. So we saw that here it looks more of a triangular shape in the medial and lateral view in the 2D cut of the apical chamber, four-chamber view. So, and this is the apical three-chamber where we're actually looking at the anterior wall and posterior wall. And so you can use these different views to try to better understand the impact of certain clinical situations on the right ventricle. There is a lot of interaction between these two ventricles. So, like a couple dancing, if one trips, the other one will eventually fail too. And you can see that, they do share muscle layers, especially at the level of the septum, and they are eventually, coupled in certain ways where the failure on the RV side will impact the LV for sure. When we look at some of the metrics we have at bedside as well as for research, we'll try to very briefly go through some of those to try to understand how we sometimes try to phenotype these babies, both in research as well as for clinical decision making. Many of these markers by echo are what we call load dependent. They will depend on if you're increasing or decreasing your afterload versus if you're increasing or decreasing your preload. So you have to be aware of that when you try to quantify the physiology at the bedside, which may change and be very dynamic. Many people will use eyeballing, which does not allow you for quantification of measurements on the longitudinal space as well as for robust, phenotyping within the research space. But here you can see what a normal left ventricle and right ventricular function would look like with eyeballing versus when you're seeing a patient with profound biventricular dysfunction, you see these ventricles that are barely not moving. So, clinically, we can see these two patients are quite different. And even clinically at the bedside, I think, these patients were also very different in terms of their perfusional status. But when you have more subtle changes, like on the on this patient, you see that there is RV dilatation relative to the LV. There's some degree of RV dysfunction since this area doesn't change much in time. And this was in the context of a severe pulmonary arterial hypertension. Versus in this patient who has systemic hypertension, you see that the LV may have some struggle, although depending on your level of experience, eyeballing you may not pick it up. And so that's why, most NPE guidelines will highly recommend to use metrics that we can actually quantify. Most commonly, there's the shortening fraction, which uses what we call the M mode or motion mode, which looks through the interrogation line. And through this kite, you're able to follow the walls of the left ventricle, and you can actually see the fraction of what's happening in diastole versus systole. But it's been discouraged by ASC in the context that it's very angle dependent and really provides you information about a certain segment. So one segment may be moving and others may not be actually participating to contraction and may just be tethered to this segment. Most commonly, we use ejection fraction. An ejection fraction, it's basically looking at the stroke volume versus the initial starting point of end diastolic volume. We have many assumptions of shape geometry of the left ventricle, so we can use mathematical model to model this in the 2D space and translate that into a 3D space. Most commonly, we'll use what we call the Simpsons, which will stack discs to try to reconstruct the volume of the left heart. But all these assumptions become very imprecise when we have situations like pulmonary hypertension, septal flattening, LV geometry that is not completely normal. And there's also a lot of a variability between intra-raters and even inter-rater up to 15%. So this is the Simpsons, where you're looking at the frontal and lateral planes and you're doing the stacking of all these discs to quantify volume in cc. But you can also use other methods like the bullet method, which will look at two views, both from the longitudinal view and the short axis views to try to quantify these volumes of the left ventricle. When we're looking at DRV, because it works longitudinally, we tend to use metrics that will reproduce this, one of them being the TAPSE, which is the motion of the tricuspid valve and how far and how deep it plunges in the RV cavity. Of course, you will see a very nice wave of motion of the tricuspid valve if you have significant tricuspid regurgitation because it's pumping, into a really low pressure chamber, which is the right atrium. So that's what I mean about, being load dependent. And TAPSE will provide information about a distance, but not necessarily a speed. I'm not someone who runs very fast, but I can travel very far. It doesn't tell me everything about my performance profile, let's say. So there are normative values that have been published, and there are calculators that you will find to provide you Z-score by gestational age. But then again, you see that it stops at 26 weeks, and we're currently working on establishing some norms for babies that are younger than that at their birth time. Fractional area change is another way to try to understand RV performance. These are the two views that I had mentioned, one from the lateral medial plane, which is in the forechamber, the other one from the anterior posterior, and there are normative value by gestational age. Tissue Doppler imaging, this actually provides you information about velocity, so the speed of motion, and not necessarily about the actual distance that it travels. It is angle dependent. It is also load and heart rate dependent, like most measures. And you can use that to actually calculate both speeds and the duration of certain mechanical period of the heart. So this can be obtained at the level of the right or the left ventricle or the septum to provide you information about the both ventricles. But again, it provides you only information in the longitudinal space when you're acquiring them in that view. And it doesn't tell you everything about if there are segmental anomalies of motion. So typically we'll look at these, what looks like wiggles, but, the systolic phase to see how fast you have contraction or motion towards the apex in systole. And you can also get diastolic properties from these waves. We'll talk of this a bit later. And there are normative values both in the preterm cohorts and the healthy term newborns. And the group from Ireland who published their data, and there's other groups who've published their data about these metrics as well. Output estimate is really the end result of this filling to ejection profile. While it's being a lot used in the NPE literature, it's less used in the cardiological literature, although there's more and more data using this, especially for ECMO decannulation. So what we use is we use the concept of Doppler to estimate stroke distance. You can obtain the Doppler in the, at the left ventricular outflow tract, and then use the diameter to estimate cross-sectional area, assuming that it's a perfect circle, which is not. And then use this to calculate what we call left ventricular output, which is indexed to weight of the baby. Typically around 150 to 300 is within normal limit. And what you do is that you get the instantaneous speed in the outflow tract and actually get an area under the curve, which provides you a velocity times a time, which gives you a distance and is correlated to stroke distance. You can do this also at the level of the RV outflow tract, and there are calculators out there. I've put you QR code. There's been normative values, but obviously there's a lot of variability between users and depending on how you trace your diameter. This is also extremely dynamic. It is useful also to just look at the shape of this Doppler pattern. This is an example of a patient with poor LV output with diminishing velocities and stroke distances estimate. And this is a patient who barely had any kind of RV output with very low RVO TVTIs. And this patient was actually in a context of almost had a functional pulmonary valve stenosis and required rescue therapy. Now, output will be influenced also by altered preload, so not just altered contractility. So this is, for example, a patient who had very decreased preload, very collapsed ventricles, and actually normalized after fluid resuscitation. While some patients who have more of a picture of distributive shock where SVR are very low and you become very hyperdynamic, may actually have an initial phase of extremely high output to compensate, so high flow to compensate for the low resistance in order to maintain pressure. And eventually, you rescue these patients by at least presumably increase vascular resistance in the systemic compartment. Finally, more of the emerging measurements are strain. Strain actually typically will use the technology of speckle tracking to quantify changes in areas of the heart, of the myocardium. So you track the pixel from the old to the new location and measure distances and how much it shortens or lengthens depending on systole and diastole. And you can apply this to the right or left ventricle. So this is an example of different views where you can apply this in 2D to quantify how some of these areas may actually participate or not to contraction or relaxation. And so that's the example of the patient we had with systemic hypertension who had a disturbed strain in areas of these ventricles not participating to the cardiac function. And this is one of the metrics we use in the research lab to quantify RV and LV function. So you can apply this to 3D reconstruction. We do a lot of 3D in our research projects where we obtain this even in babies around 800, 700 grams. This is an example of a 1 kilo baby where you can actually reconstruct the left ventricle and obtain metrics of ejection fraction and stroke volume, but also of this deformation by following globally the walls of the left heart. You can also quantify some of these more novel and research-oriented metrics like the rotational properties of the apex and the base of the heart to try to understand if there are certain signatures of phenotype. This has been described in the adult population. And then recently, we've been actually manually segmenting the left ventricle. This is an example of ex preterms who are now at 40 weeks, and 24 controls by one of the students in our lab who actually, show different techniques to segment the left ventricles and its correlation in order to make it a user-friendly method to better quantify cardiac function at the bedside. We can apply the same principles to the right ventricle. Thankfully, with 3D, you're able to get all the walls, so you're able to actually reconfigure the volumes and obtain ejection fraction. Silviane Nogara, who's an Italian neonatologist, did a project in our population of patients where she looked at 151 preterms who are now at 36 weeks, and we obtained 3D echo on these patients. And what she found is that there was definitely changes in their end diastolic volume by 3D echo depending on the weight they were or the birth gestational age, despite the fact that these patients had all reached 36 weeks and had similar weight and length. And she also found a sex signature. So there are different patterns that we can find using these tools. We also looked at the population of 147 extreme preterm infants and classified them either they were on room air or not at the time of 36 weeks and found that there was, of course, some differences in the right ventricular properties of these patients with more significant lung disease, potentially outlining that there's some degree of lung and heart interaction in these patients. Now, for diastology, there are, great articles out there trying to better decipher what is diastolic heart failure in some of our preterm infants. When I see this list, my first reaction is kind of this. I get very overwhelmed. I think some of the challenges that we have with defining diastolic heart failure in preterms is that, or term even babies, is that these patients have underwent a fetal to postnatal transition that is very dynamic. There's of course persistence of fetal shunts and fast heart rates. These patients also have dramatic remodeling of their RV and LV in the postnatal life with changes in the afterload of both ventricles. And then there's many conditions we face in the NICU that will affect both the capacitance as well as the speed of relaxation. So hypertrophy, myocardial fibrosis, inflammation, or arrhythmias, some of the cardiorespiratory interactions, as well as some of these interactions between the right and left heart. So I've put here just a table of some of the common things that we tend to look at when we're thinking about diastolic issues. We, of course, look at the interatrial shunting, which depends on ventricular compliance. We look at some of the dimensions of the atria and the ventricles. We look at the upstream effect on venous return, whether or not it's causing pulmonary edema or big livers, what's happening at the level of the inflow velocities or filling of the heart, the relaxation properties of this muscle, and we use sometimes speckle tracking in the research space. So RV-LV crosstalk can be understood at the diastolic level, depending on your shunting at the interatrial shunt level, which can tell you some information, but not all information, but really is dependent on the compliance as well as the venous return. Some centers will use right atrial planimetry or an LA volume estimate, but you can see how there could be variability in where you measure and how you measure it. And there's not great data in the neonatal population. And, if you obviously have big interatrial shunt, you might offload an atrium and not get dilatation. Venous return, so pulmonary venous Doppler are interesting to look at when you're thinking that there's high LA pressure, unless this left atrium is able to decompress into the right atrium via a PFO or an ESD. But if you have a lot of retrograde flow during atrial contraction or prolonged duration of that, it is a concern that LA pressure, filling pressure might be increased. Same thing as VC or subhepatic venous flow. If you have a lot of retrograde flow during atrial contraction or prolonged duration, it's a bit of a concern for right atrial hypertension. Inflow velocities have been described a lot in the adult population. We just don't have great data in the newborn space. We know that if we increase significantly the preload of the left atrium because of the PDA, you get very high E-on-A ratio, which is the early phase of filling versus the active phase during atrial contraction. But in babies, they might be often fused because they have fast heart rate and because atrial contraction may happen almost at the same time as the opening of the mitral valve or the tricuspid valve. So we know even less what's happening on the RV side. The tissue Dopplers, again, is looking at the speed of re-expansion of the tissue. So this time we're looking at the phase of the diastolic filling, where you get an early phase of filling and an active phase of filling. And this muscle actually expands, and there is a speed at which it is expanding. So obviously, if you have a very stiff ventricle, you're not going to be expanding very fast. And so sometimes we can use how fast is the blood filling into the ventricle compared to how fast this ventricle is able to expand. We call this the E-on-E prime ratio, which is one of the more sensitive things they use in the adult population, but has not been valued in the neonatal space. I think speckle tracking for research will provide us more information. We do look at some of these metrics in the research space. So this is an example of a diastolic strain rate where we look at the early phase of filling and how quick this myocardium is able to re-expand in terms of its, deformation. We can also look at the atriums, which obviously are the reservoir that are about to fill the ventricles. And when there's high filling pressure, these atriums may start to misbehave. But this is really preliminary work. We've recently dabbled into the work of flow kinetics. We're using echo to better understand how there's vortex formation within the heart and try to understand how there's energy dispersion into the heart. So you can use that like a bit of a toilet bowl. If you kind of pack your toilet bowl with a lot of toilet paper, it's going to block and things are not going to go well in your home. But if you have a very good contraction relaxation, you get very smooth vortexes, very smooth flow into your toilet bowl. So it's kind of similar concept to apply into research. So we've just finished a cohort of 52 patients where we looked at the left and the right ventricle using these technologies. It's a collaboration with Purdue. And we actually started to outline some of these normative data for the RV and the LV on flow kinetics, vortex flow, suction pressure. And now we have cohorts of preemie, HIE babies, CDH patients that we're going to compare to try to see if their signature and whether or not they actually relate to some of these important outcomes or outcomes that we measure. Why is it important? It's because alteration in cardiac function are associated with adverse outcomes. Might not be causal, may not mean that if you rescue it, you're going to change your outcomes. But I think more literature to come on that and more trials hopefully to come on that. But that's been very consistent across prematurity, HIE, CDH, and fallacial congenital heart patients. The work from Toronto from Dr. Gissinger was very instrumental to show that in HIE, significant RV dysfunction was already associated with brain injury. We showed that in one of our cohort when I was at Stanford, using both strain and conventional markers of cardiac function. And we also shown that in HIE population of neonatal encephalopathy using 3D echo. That's been consistent in many other population, including the preemies, including the CDH babies. Um, More clinically, why is it important? Because I do think that until we get more RCT results, the best that we have is physiologically guided care. And yesterday, Dr. McNamara actually provided an outstanding lecture on this. If you have, of course, contractility issue, you're going to think about providing support for inotropy, output concern, you may need to reopen the duct. And if you have diastolic concern, depending on what's the cause, you may you may provide more preload or heart rate modulation or tamponade drainage, for example. And at the bedside, of course, echo provides you information as, an NPE practitioner, but you really have to go back to the bedside, look at your baby, understanding what's been the trajectory, understand the physiology, and then follow your patients. It's not just about the echo and treating the images, it's about putting the whole thing together. So I do think that recognizing cardiovascular physiology is important, both for clinical aspect, but also to phenotype and quantify this for research, whether it is research on stem cell therapy that you're providing for BPD in a trial and understanding its impact on the heart, or if you're looking at directly cardiovascular management and trying to understand how these patients are quite different in terms of physiology, spectrum, and the dynamic nature of their cardiovascular system. So in conclusion, I do believe that clinically functional assessment must be individualized, integrated in the bigger clinical picture, and that TNE can provide some complementation to the phenotyping and guidance, as well as titration of therapy. As a scientific and a community of researcher, I do think that our metrics, whether it is currently available in conventional or in development, provides some more nuanced information that we're able to mechanistically link to adverse outcomes or potential, targets for therapies, and helping also for guidance or monitoring into trials. So we're currently doing a trial on sildenafil. We're actually monitoring the effect on the heart, as an example. But of course, like any tools, it has limits. It must be recognized. And hopefully in the future, we'll be able to actually complement this with both additional technique to understand perfusion monitoring and organ integrity, but also link it to important patient outcomes and, maybe do things smarter by using tools like AI to actually link it with some of strategies of management that can be tested. So thank you for attention, and I've put my email there if you have any questions or comments that you wish to share with me.